The diagnosis of it is done in various ways, from entry-level, somewhat inaccurate, to the most accurate gold standard measurements of it. So take a moment and go over that now. The first assessment of it is the very visual one. It's the one that you or I would do if we were in the grocery store and we notice someone standing with a strange posture. That's where we're just looking at the length of the person's limbs as they're standing there. You may see the belt line tipping down on one side. You may, if they're wearing shorts, notice that one kneecap is higher than the other if you're facing them, or looking at them from the back, the little crease behind the knees may be uneven. That's your initial visual assessment as you're looking at an individual. And the next means of doing it visually would be to have them lying on a table where you just simply look at the length of the legs as they're lying on the table. Both of those are helpful, but neither one of them tell us exactly how long or short the limbs are at that point. And the problem with the lying or the supine measurement where the person lies on their back and you look at their leg length is as soon as they are out of gravity, as soon as the pelvis meets the table, the whole body can shift and throw off what you're looking at. So the measurements that are done, even if we're using a tape measure for the limb length with the person supine, is not an accurate way of evaluating. The next level of evaluating is to have the person actually stand on blocks or tiles while you're looking at them and palpating bony landmarks. And that can be more accurate, and the patient can give you more feedback. They can say, yes, that feels very even to me, or no, that feels like I'm tipping in the other direction, or I still feel like I'm stepping down into a hole. But typically what we will see if a person has a musculoskeletal complaint when they come in to talk with us is that as soon as we correct that limb length with blocks or tiles, they start to report relief of their symptom that they presented with. The next level of accuracy with the diagnostics is a standing A to P, or anterior to posterior lumbar x-ray. And that is an x-ray that shows us the pelvis, the femoral heads, the spine, all on the same film. And quite simply, we're able to measure up from the bottom of the film to the top of the femoral heads, and we can assess limb length discrepancies with that film there. The problem with that is if the patient shifts their weight from one side to the other, or if we've got some compressions in the large joints as they're standing there, that's going to throw off that measurement a little bit for the anterior, posterior, or A to P lumbar x-ray. The gold standard really for evaluating the limb length discrepancies is called an orthoröntgenogram. And that is an x-ray that shows us the hips, the knees, and the ankles all on the same piece of film with a ruler run down the middle from which we can measure over from the bony landmarks and be able to measure very accurately the length of the femur on one side, the length of the femur on the other side, the tibia and the tibia, add those lengths together, and then subtract the difference, and the number that you're left with is the exact limb length inequality. Plus, it gives us the ability to tell exactly how long the limbs are, the bones are in the lower extremities. So that is considered the gold standard for the measurement of limb length discrepancies.